Okay, so this section in Unit 4 completely switches over to more of a med-surg context. It was a requirement at one point that all courses integrate some aspect of med-surg nursing. So in this unit, we're going to have kind of a review of your perioperative nursing and anesthesia, some postoperative complications, and then male and female reproductive. We're going to start out with perioperative nursing, anesthesia. This encompasses your Brunner textbook and chapter 17 through 19. So first off, when we're talking about perioperative nursing, what does it all include? Perioperative includes, peri means around, right? So you've got preoperative, intraoperative, and postoperative nursing. So preoperative phase starts from the moment that the decision is made to go ahead and pursue surgery until the patient is actually transferred into the operating room. So sometimes these surgeries are scheduled months out in advance, right? Well, that's still considered preoperative nursing because during that time, required tests need to be completed. If they've had any cardiac history, they're going to need an EKG workup. They're going to perhaps need to be cleared by cardiology before they're going to be considered stable enough for surgery, yada, yada, yada. Intraoperative is the time from the time that the patient hits those OR doors to the time that they are admitted to the PACU or to the post-anesthesia care unit. And postoperative is that time as again an extended period of time, which is from the time that the patient is hits the PACU all the way until they have their surgical follow-up, and usually that's completed in the clinic by the surgeon. So some indications for surgery include like diagnosis. So this would be like if we're doing an exploratory laparotomy or laparoscopic surgery, when we're looking for a reason for some abdominal pain that the patient is having that we're not being able to see on imaging. Cure would be an appendectomy. If we have appendicitis and that's the causative factor, we're going to cure that condition by removing the appendicitis. If we've had multiple stab wounds, surgery is used to repair. If we've had breast surgery, if we had a double mastectomy and now we're going to go back in and do some plastic surgery for those breasts, then that is a reconstructive surgery, a mammoplasty. Palliative, if we've got a large tumor that's pushing on a spinal nerve and it's causing a ton of pain, but the patient necessarily doesn't want to pursue any further surgery, they just want pain relief, if we've got a tumor or etc. So we'll go in and we'll debulk that, remove that, and let them go on. If you've got like a chronic gallbladder issue where it's perhaps not inflamed right at the moment, okay, but we've had sequential times where it's become an issue, then we might go in and cure the issue there. See, it's palliative though. It's not curing. It's palliative. And rehabilitation, like a total joint replacement where we're taking out and moving something there. Classifications of surgery can be based on the urgency involved. So you've got emergent, urgent, required, elective, and optional. Traumatic, emergency, or even scheduled surgeries that are 6 months out in advance can all be stressful to a patient, and does not matter if it's a required surgery, an elective surgery, what have you, they all may result in long hospital stays. There are two types of surgical settings that you should be aware of. One is the traditional inpatient that you are probably somewhat familiar with. And then the second is outpatient, where you have like your ambulatory care center, your ambulatory freestanding surgical centers. So things like your there's a Rockford Day Surgery, there's Rockford Orthopedics. Some of these places actually, you go in, you have your surgery, and you go home, okay, that same day. They don't have 24-hour nursing care. Now, with that being said, there are some definite advantages to it. One, patients recover quicker at home. We all do better in our own home where we're surrounded by our own germs, where we're surrounded by the people that we love or don't love, but that we're comfortable with. We have a decreased risk of acquired infection from an in-hospital setting. You see a lot of trending towards these because obviously this is going to be less money for the insurance company, faster recovery time in theory for the patient. The OR time, as you can see there, the criteria for these surgeries is going to be anything less than 2 hours. Now, with that being said, we usually compensate by having them a little bit longer in PACU, because patient education, making sure that they're going to have a healthy transition to home, discharge planning, preparation for self-care, case management, referrals to home health services, rehab services, all of that has to be integrated prior to these same-day surgeries. And then in addition to that, we need to make sure that before those patients go home, that they really have a thorough understanding of what's occurring. So some key aspects of perioperative nursing include communication, teamwork, patient assessment, and safety. Anything, that's going to be a main focus for the surgical team. All members of that surgical team are working together to meet those goals. So some things like the SCIP project, so the Surgical Care Improvement Project, was implemented as part of the Joint Commission and Centers for Medicare and Medicaid Services. And what this means is that all of the members of the healthcare team are working together from different aspects, from a nursing aspect, from a surgeon's aspect, all from different points of view to prevent surgical site infections, venous thromboembolisms, and other postoperative complications. When we're looking at who encompasses the surgical team, first and foremost, we are talking about the patient. The patient definitely is going to be a lot of a reason, perhaps, that the outcome is good or negative. Does the patient cooperate with preoperative workup? Does the patient understand the patient education? Does the patient participate in postoperative rehab services? Circulating nurse coordinates the care of the patient in the OR, the patient positioning, preparing the site for surgery, managing specimens, anticipating needs of the surgeon, documenting intraoperative events, and also ensures that consent has been signed. So this is really a leadership role, as you can see all the different aspects that nurse is doing, ensuring cleanliness, OR temperature, humidity, light, safe functioning of equipment, availability of supplies and equipment, monitors aseptic practices as personnel move in and out of the OR, people like x-ray technicians who might be called in to do an x-ray of a bone and make sure that it's cut, that it's in place from all different angles. And they're monitoring, they're responsible for ensuring that the timeout is completed. The scrub RN or surgical tech, that role provides sterile instruments and supplies to the surgeon during the procedure. They set up the sterile equipment, they set up that sterile field, they again are also going to anticipate the needs of the surgeon. They count all the needles, the sponges, and instruments at the start and near the end of the surgery to make sure that they're all accounted for. On the RN first assistant, the exact role depends on each state's Nurse Practice Act. These responsibilities can include handling tissue, providing exposure at the OR field, suturing, assisting with homeostasis, i.e. suctioning. And then, of course, we have our anesthesiologist, or our certified registered nurse assistant, and these individuals obviously are going to have that huge task of making sure that our patient remains both sedated and hemodynamically stable during the OR procedure. So one of the some of the principles of surgical asepsis that we really need to be cognizant of include the prevention of contamination of the surgical wound by natural skin flora, pre-existing infection, or circulating pathogens. For example, we're going to make sure that there's strict sterility of all the supplies and equipment. Any infected wounds are going to be covered. We're going to make sure that we are scrubbing in prior to surgery, gowning and masking. we're going to have that antiseptic solution that's applied around the post-operative, or excuse me, the operative site. For you, those of you who currently work in on the medical floors as techs or HUTs, you guys are going to be aware that we are now doing antiseptic showers prior to surgery, before we go down for surgery, and perhaps even upon return back to the unit, trying to minimize the amount of skin flora that could possibly contaminate that post-operative wound. We also might obviously do hair removal and shaving or clippers as well. The environment, this is like super, super important. So cleaning between cases and ventilation and air filtration. So within the past couple of years, there was a case over on the West Coast where a children's hospital was conducting surgical cases in their OR, but their ventilation system was not up to par. And you go back to that concept, then, one of those principles of surgical asepsis when we're talking about circulating pathogens. And when the ventilation system was not up to par, it allowed those pathogens to circulate. It also allowed fungal spores to grow within the ventilation system, and multiple children died as a result of postoperative infections from fungal spores that were all traced back to the environment ventilation system. So super, super important that everything is being cared for in that way. Decreased number of non-essential personnel. So when we're considering how many med students, how many surgical tech students, how many nursing students, how many CRNA students, when we're looking at all of those individuals, we want to make sure that we're maintaining a safe number, that we're backing down maybe on the number of essential personnel, or non-essential personnel, because obviously that's just an increased risk for infection. We maintain temperatures in the ORs. Those are historically kept a little cold, between 68 to 73 degrees, again, to decrease and discourage pathogens from growing. So some basic guidelines within the OR environment. All material within the sterile field must be sterile. So you guys, think about your flushes on your IVs. Are your flushes sterile? No, they're not. So would we be dumping a flush onto a sterile tray? Absolutely not. That would be handed to the individual. Gowns are considered sterile from the front of the chest to the level of the sterile field. Sleeves from 2 inches above the elbow to the cuff. So again, anything below the waist is considered dirty. Only the tops of the draped tables are considered sterile. Anything on the sides is not. And then we're going to, when we're, think about how you guys use sterile technique when you're doing your catheterization of your male and your female in order to obtain a urine specimen, and how you move in a way to, like you're going around the trash can because you're trying to, or going around your sterile field to the trash can in order to maintain sterility of your clean area, right? Same concept when we're talking about surgery. We're not going to be overlapping that sterile surgical field with our dirty stuff. So we're always going to move from sterile to sterile, from unsterile to unsterile, never back and forth. When we're talking about the implications of the perioperative phase upon nursing staff, we have to talk first about medications. So a really thorough pre-medication assessment, having all of that documented, is going to be huge, huge, huge. Some medications taken prior to surgery can interact with anesthesia, increasing or decreasing the potency and the effectiveness. We also might increase or decrease the desired physiologic response or effect. And so we want to have a current med list, which includes obviously prescribed medications, the dose, when they were last taken, herbal products and supplements, and then your anesthesiologist and a specialist especially is going to be interested in this med rec. Your higher risk medications include antihypertensive, so beta blockers. So again, this doesn't fall back on the surgeon, this falls back on the anesthesiologist as whether or not we're going to administer a medication that's going to effectively lower the heart rate prior to surgery. Anticoags like aspirin is usually held 7 to 10 days preoperative, and then insulin. Once again, if you're a med surg, you need to absolutely be sure that your patient who has a planned procedure has clear instructions on whether or not to administer insulin the day of surgery. You also may want to consider switching them from a normal saline to something with a little bit of sugar if you're going to be giving insulin. We're going to be talking again and again and again, as you guys go through the rest of your nursing program, about why managing blood sugars are so absolutely important for key optimal outcomes for your patients. And in surgery, it's absolutely no exception. The preoperative nurse is also going to take a physical assessment. So we're going to address that nutrition and fluid status. You have to be aware that if any bowel prep or NPO status is going to leave your patient dehydrated, right? So is it going to be easier for you perhaps to start that IV line? Maybe not. And that might become part of an issue. We might also need to be concerned about chemical imbalances if our electrolytes are off. Our anesthesiology team is going to want to really know about any plates, partials, dentures, or cavities that a patient may have. So taking a good look inside their mouth as well, or asking the patient about those. Those can be dislodged during surgery, during intubation, and include the airway. Illicit drugs can potentiate or depress the effects of anesthesia, so if our patient is willing to disclose those, we definitely need to be asking that. And then obviously alcohol use is going to decrease our immune response as well, so something to be considering in the post-operative time period, and important to pass along. Also going to assess respiratory status, cardiovascular, hepatic and renal, endocrine, and immune systems. We're going to ensure that our allergy list is up to date, which includes information on latex allergies. Some certain foods like kiwi, if our patient has an allergy to that, can be an early indicator of a building latex allergy. So we want to ask these questions. Check our current labs if they're available, and always, always, always make sure some sort of H&P has been completed. In addition, we're going to provide some psychosocial interventions. As I mentioned before, these patients can be very stressed. So the perioperative nurse's role is going to be looking at reducing anxiety, decreasing fear. We're going to make sure that we have made note of and that we are respectful of cultural, spiritual, and religious beliefs. Again, this is a high-stress environment for this patient. This is the time that they are praying. This is the time that they are wanting to see their significant other, and we have to really obviously be cognizant of that. Things that we do to maintain patient safety, because we're going to start administering medications in this phase, so the patient can become a little bit more, they can start to loosen more of their inhibition. So we're going to make sure that both of our side rails on our gurneys are up. We're going to make sure our IVs are started, that we've got fluids running. We're going to prep the bowel if there's anything like that we need to help or assist with, and then preparing the skin, making sure that the surgeon and the patient both notate the appropriate surgical site. Informed consent, if you've ever sent a patient down to surgery, you would know that they always want to know where that consent is at. Is it electronic? Is it paper? Has it been signed? Has the surgeon been up there? Has the anesthesiologist been up there? Has anybody been up there to talk to the patient? Okay. If they have signed a pre-op consent, well, where is it? I need to know it, where it's at. It goes part of the patient's medical record. It's the chart. It explains in that consent that the surgeon has said, this is why you need to have this procedure. These are the risks of the procedure. These are the risks if you don't do the procedure. And these are the benefits of the procedure. Okay? If it is an emergent situation, you may not have a consent if we don't know who the patient is. I'm thinking like some of our gunshot wounds, our huge traumas. Obviously, those are kind of extenuating circumstances, but for everything else, we should have some sort of consent. Okay? And then there needs to be in there that there is a statement if informing the patient if what we are doing differs from the customary procedure. So if we're going to open them up for an open appendectomy instead of going in and doing it laparoscopic, and why. Okay? Now the nurse, is the nurse the one signing the consent? Absolutely not. Your signature should only be on there as a witness. You should not be signing for the surgeon at all, okay? This is the surgeon's responsibility. So when they say, is the consent on the chart, and I haven't seen a surgeon, I say, yeah, that's right. The consent's right there. It has not been signed. The surgeon has not been up. But what I have done is I have put on the label. There can be orders that go in that tell you what to write on the informed consent, but honestly, I just prefer that the surgeon do that because they're the ones that know exactly what the plan is, okay? Some nursing interventions within the immediate preoperative phase. So right as we're getting ready to head back to surgery, we're going to do the pre-anesthetic medication. We're going to make sure, usually for most of our surgeries, we're going to make sure that operative antibiotic is hung and rolling, making sure that we know where the perioperative record is, making sure that we're documenting. Please make sure that you're documenting all of your medication administrations, transporting the patient, and then attending to family needs. So communication, communication, communication. So some types of anesthesia that you need to be aware of include local, so that's all the way down at the bottom. Okay, and that's as simple as your lidocaine, right? A little bit of EMLA. Those are all kinds of forms of basic local anesthesia. We have a peripheral nerve block where we sedate the entire arm, an epidural, which goes from the nipple line down, the spinal, which goes from the hips down, and general anesthesia in which the patient is intubated and completely put out. So when we're talking about, again, local anesthesia, as I've talked about in the past, when we're talking about like a tear repair for a patient who has had a vaginal delivery, remember I talked about way back, most of these, the lidocaine is mixed with epinephrine, and that constricts the blood vessels, prolongs the localized action, and it also prevents the medication from becoming systemic. So lido will be bupivacaine. And then here we have our regional anesthesia, our epidural, or our spinal, in which, once again, hopefully you've had an opportunity to watch an epidural be put in during your labor observation if you've had the opportunity to do that. So here we are, we're providing that patient with a loss of sensation without the loss of consciousness, and just injected around the nerves, resulting in anesthetizing sensation for those nerves. Moderate sedation or conscious sedation. Here the goal is to depress the level of consciousness enough to enable the procedure to be completed, but the patient is not completely out. Obviously this has to be monitored very closely because you don't want to go too much or too little. We have to be able to convert to general anesthesia. These typical procedures are done for people who either are having very minor procedures or if they're unable to withstand general anesthesia. So when we're talking about these medications that we give, we're going to be giving a whole host of different preoperative medications. We've got our basics, and then we add other things to them to potentiate those effects, and those are called adjuncts. So some of these medications include opioids, benzos, NMDs or neuromuscular blocking agents, and antiemetics. These are often given on the way to OR, including like those antibiotics that I talked about being hung. Your preoperative nurses are always going to want to know when was the last time that you gave your patient a pain relieving medication, whether it be Dilaudid or morphine or Toradol. They want to have that kind of, or Affirmative even, in the back of their brain before they take this patient down to surgery. Annotate that so that they have an idea of when the next dose should be, or if we need to increase the dose. Analgesics are used preoperatively. These can be, we don't use morphine like just in the OR setting. We use it on the way to provide some sedation, to provide some pain relief, especially for patients who are in pain and headed to the OR. We can also give maybe a little bit of fentanyl. And then those benzos provide a calm hypnotic state. They decrease anxiety. They might produce some a form of amnesia as well. So if you have a patient whose surgery keeps getting pushed back and they're becoming more and more anxious, we might be looking at some benzos to help them. Barbiturates are CNS depressants that are used for sedative, hypnotic, and anti-seizure effects. There are more effective drugs for the OR, but these might still be used to decrease anxiety and cause drowsiness. They can be used in high doses to provide or induce, anesthesia, and these will have the suffix "all," like secobarbital or pentotal. Benzos, this is another class of drugs, as I already mentioned. These include Versed, Valium, Xanax, and Ativan. Again, the whole point being here that these are going to be used in different combinations to produce the desired effect, and it also depends upon the patient's state. Anticholinergics, like our atropine, Robenal, scopes, these decrease oral and respiratory secretions. They prevent bradycardia. So if you've ever seen a scope patch, scopolamine, it's usually placed on behind the patient's right or left ear. They can also be used conveniently for seasickness. So patients going on cruises might request scopolamine if they've had an issue with that in the past. Anybody who has a history of postoperative nausea and vomiting, where they react terribly to the effects of anesthesia, might have the scopolamine in place. And then in addition, we're going to adjunct that again with antiemetics like our Zofran, Reglan, and Compazine. Zofran we usually give as 4 milligrams. You can go up to 8 fairly easily. Induction agent, so now we've got our patient nice and calm. We've got them as relaxed as possible. And then in addition to that, we're going to have our antibiotic running. We've got our site marked. We've got our site scrubbed. Now it's the time to go ahead and start giving a few drugs to help induce or maintain anesthesia. So our inhaled agents, these would be given preferably by anesthesia, okay? So inhaled anesthetic agents, they provide amnesia when the patient breathes them in, when they inhale those medicated vapors. However, with that being said, these induction agents can produce a buzzing, roaring, or dizziness sensation. So obviously, at this point, this is when you hope that your Ativan and your Xanax have helped, and they're going to provide that amnesic effect, so that your induction agents, when you're inducing your anesthesia, will also be effective and be very comfortable for the patient, because nobody's going to like a loud roaring noise in their ear, right? So some of our IV induction agents include propofol, like Diprovan, which is called mother's milk, is another way to describe it, because it's like thick white, looks like milk. Very short acting, used for induction of anesthesia in short procedures, works within a minute, wears off within 8. And then Versed, you can use like higher amounts of Versed to produce anesthesia. Can also be used for moderate sedation. I've also seen, not that I am advocating this in any way, shape, or form, I've also seen it used on kiddos to help them calm down enough so that like the stitches can be placed or whatever. So this is a hypnotic and amnesic. It produces some amount of sedation. However, it can also produce some respiratory depression, apnea, or oversedation as well. Neuromuscular blocking medications. So these interrupt the transmission of nerve impulses at the neuromuscular junction. We're going to talk about here in just a second the non-depolarizing and polarizing classifications. They provide relaxation of skeletal muscles, and essentially they're going to help us facilitate intubation. If everybody's muscles start to clamp up, whether we're conscious or non-conscious, these body parts still work, right? You still have reflexes to some extent, and we're going to have a constriction of those muscles. However, we need the muscles to be relaxed as possible so that we can provide the surgery without that clamping sensation. So we're going to give these neuromuscular blocking agents. Now, depolarizing. These are going to act by binding to the acetylcholine receptors and generate an action potential, but they are going to inhibit the repolarization, so we have a synaptic block. So succinylcholine is the depolarizing neuromuscular blocking medication. There is no antidote to Sux, but it is widely used because of how quick it goes and how short acting it is as well. Again, this one is going to act within a minute, and it's going to last only about 7 to 8 minutes. So if we need a little bit of relief, this is the way to go, because we don't want to depress that respiratory drive or that muscle sensation for that long. Non-depolarizing, these work a little bit different, because this one actually binds again to the receptors, but it prevents the action potential from ever occurring. So these include mivacurium, rocuronium, or pancuronium. So the point here being, with these neuromuscular blocking agents, that when you're breathing, okay, once again, if you're sedated, and you're coming out of that sedation, that level of consciousness is inhibited, but your respiratory drive is still working, right? And so we've got muscular, the muscular movement of your breaths. And if once we start to wean these medications, it is, so absolutely important that the nurse is monitoring the adequacy of respiratory muscle movement as the surgical case comes to an end. Again, this would be, your CRNA or your anesthesiologist, but in the PACU as well, making sure that your patient is able to maintain those breaths before we completely take away all of the aids that we have given them to breathe. So LMAs, couple of different things that we have here, so to aid our patient in breathing. So LMAs are used for some procedures. They're not always such a hot topic, but basically it sits right over the vocal cords and closes off the epiglottis. Is kind of placed over that, and then the LMA, the provider can attach ventilation tubing and whatnot to this, and adequately perfuse the patient that way. Endotracheal tubes, or the ET tubes, obviously these are going to be far more common, and this does require very skilled placement of these. There are probably 50 or 60 different types or brands of ET tubes. You've got the cuffed, this one's a cuffed, there are uncuffed ET tubes, different sizes, and of course those are being placed with your scope, okay? And then the eye gels, so the eye gels, the patient might, so you have here, you've got, you've got a couple different things here, but what I'm showing you, so over here on the LMA is the one on the far left, but the eye gel is over on the far right. And the eye gels, so your patients who are trauma patients who are coming in from the field on the rig from the ambulance, they can have these eye gels in place. Now the eye gels are, like I said, much more common. There's a YouTube video there if you're interested in learning a little bit more about how those are placed. And the eye gels come in all different sizes, and that's what's pictured there on the right. So these are now more common than what you used to see with the LMAs. So again, so the whole idea here when we're talking about medications and providing that amnesic experience, these patients are going to inhale a gas or a vapor as well as having some IV access. During inhalation, it's most commonly given nitrous oxide along with O2. During inhalation, the drug enters the blood through the pulmonary capillaries, acts on the cerebral centers to provide loss of consciousness and sedation, and then it's breathed off and eliminated through the lungs. So general anesthesia. General anesthesia, the whole idea here is to produce CNS depression, to provide analgesia and relaxation, and we are passing the blood-brain barrier in order to do that. These patients who are under general anesthesia are not arousable even to painful stimuli. Obviously, that's the goal. We're cutting and dicing, slicing and dicing. We absolutely do not want these patients to be able to feel this. We will need to do ventilatory support in order to maintain a patent airway. Why? Because we've depressed that respiratory center. In addition to that, they have neuromuscular blocking agents on board. So we need to be ventilating their lungs because their bodies are not going to do it for them. Their drive isn't there, as well as the skeletal muscle support. The higher levels of anesthesia can be administered at the onset of surgery, but as the tissues become saturated, less and less medication has to be given. So the stages of anesthesia, this you can reference in your Brunner book on or about page 443. So it's important that you know what these are, simply because as the patient arouses towards the end of surgery, these stages occur, but they occur again in reverse. Okay, so it is also important to note that when we give narcotics or neuromuscular blocking agents or relaxants, these stages can occur seamlessly, or it might seem to skip stages as well. And again, we're going to initiate our anesthesia by means of an IV drug, and then we're going to maintain that by inhalation. So the first is beginning anesthesia. So this is where we talked about that roaring, ringing, buzzing sensation, that loud amount of dizziness, okay? So although they're still conscious, they can have this inability to move these extremities easily. They may become very heavy. Noises are exaggerated. So what do we do to decrease these unpleasant effects? We give those other medications like our benzos. Stage 2 is excitement. So here we have struggling, talking, shouting, etc. Again, this isn't really pleasant. So again, we might be able to smooth into stage 3. But be aware once again that in the PACU this is happening in reverse, so you're going to have this patient that might have this struggling, shouting, talking as they become awake. The pupils dilate, but they constrict if they're exposed to light. The pulse is rapid and the respirators are irregular, and we need to be concerned for vomiting during this stage and provide aspiration precautions. Stage 3 is therapeutic. This is the surgical anesthesia. This is what we're going for. The anesthetic vapor or gas is being administered. It's being supported by IV agents. Pupils are small, but they still constrict when exposed to light. Respirators are regular because we're venting them. The skin is pink or slightly flushed because they're well perfused. And we are maintaining a depth of anesthesia between 1 and 4, which is lighter to deeper. And then medullary depression, this is not good. So this is when we have too much anesthesia on board, our respirators become really weak, our pupils are widely dilated, and they no longer constrict. And if we don't take care of this patient very quickly, they will die. So some complications of anesthesia include anesthesia awareness. So this is when we're partially awake while under general anesthesia. These are those horror stories that you have of the patient saying, I could hear them sawing through my knee. So our patients who are at greater risk of this are cardiac, obstetric, and major trauma patients. And again, it can be a little bit harder for these patients because we're trying to maintain a light to a dark, or we're in such a hurry that we're not waiting until they get to be fully sedated before we start doing things. Nausea and vomiting. Some patients react very, very poorly to these medications. Anaphylaxis, which of course we try to decrease the risk of, but is always a risk factor. Hypoxia with respiratory complications, hypothermia, or malignant hyperthermia. Malignant hyperthermia should be one of your postoperative complication topics, but basically what it is, it's a metabolic disorder characterized by hyperthermia, rigidity of muscles, occurs with some people who are exposed to certain anesthetics. So I would pay attention to that one because it's going to be a biggie. So your patient has undergone surgery. They had beautiful sedation, they had their procedure completed, all looks good, life is wonderful. Now they've been transferred over to your PACU. So anesthesia and a surgical member is going to transfer the patient to the PACU, and during this time they're going to maintain the airway. And then the PACU nurse is going to do, once again, another head-to-toe assessment. What does our respiratory status look like? What does our cardiovascular assessment sound like? Do they perhaps have a new onset of murmur after they've been under some stress? Maybe there was a murmur that we didn't hear before that now we do. Maybe they've lost some more blood, so we're able to hear that. Maybe their level of consciousness is deeper than what we think it should be for the procedure that they had done. We're going to look at the wound. Is it seeping blood? Is it draining more than we think it should? Is it bleeding through the bandage? What about our drains? Where are our drains? How many do we have? Where are they located? Our lines, how many IVs do we have? What's running into those IVs? When was the last time they had their medications? What medications are we talking about? Well, how much more Dilaudid can I give? How many more fentanyl? How much more fentanyl or Versed can I give in order to keep this patient comfortable? In here as well, let me see here. When you're talking about, one of the PACU nurse's responsibility is, as a floor nurse, when I have my patients, you remember I had patients that, for a long time on peds, we would take these gynae procedure patients, and for a long time, I mean, that was what we did. And sometimes I would get report from the PACU nurses that this patient had 4 incision sites, and I'd get my patient up to the floor and they would have 5, or I would be told that they'd have 1 drain and they'd come up with 2. I would be told that the sites are closed with sutures and they'd be closed with staples. You know, just kind of that sort of a thing. I'm very particular about my documentation, if you guys haven't figured this out yet. So I do not like charting that there are 4 operative sites and getting, you know, rolling my patient over on their back to get them up to the bathroom for the first time and finding out that there's another incision over there. So not exactly my fondest memories of being a floor nurse. This initial phase in the PACU, the biggest and most important aspect is maintaining ventilation. So once again, we're considering that we have all of these anesthetics on board, we have neuromuscular blocking agents on board, so we need to make sure that our patients are ventilated properly and perfusing well. If we're assessing this respiratory function and we determine that there's narcotic suppression, again, we're going to have Narcan immediately available to us. And for a moment, try and anticipate what your patient would look like as they come out of anesthesia because you have given them Narcan. What are some of the physical effects that you think or anticipate that you would see with your patient? How is your patient going to respond? And then as well, this figure is going to show you how to properly assist a patient with ventilation who's been extubated while preventing that tongue from occluding the airway. So if we've got a patient straight up and down, you can see how that tongue falls back there in figure A, and we've blocked that oral pharynx. And then figure B is if we do that little bit of a neck roll, is what we call it in NICU or what have you, we're able to straighten out that oral pharynx and actually get adequate ventilation to that patient. And so that head tilt is really forcing the tongue from blocking it. And then as well, if we're not noticing any improvement there, you can always do a lower jaw and pushing for that forward. That aids in expiration for approximately 30% of patients. So just some little tricks that you could do to help those patients breathe. We use scores everywhere, right? We use, you guys have seen a couple of different scores that we have talked about just in this unit alone, from that neonatal skin scores to, you know, you'll be using your Braden score, your Braden QD score in peds, APGARs, etc., Bishop, etc. So it comes as no surprise to you that we have a score to help us determine when these patients are appropriate to be transferred back to the floor, versus after 2 hours, if we haven't been able to get them very, very close to going to the floor, then they need to maybe go to the ICU. and recover there. Perhaps there's something underlying. So this ALJET score is used to determine if they're stable enough to be dismissed from PACU and placed back to the med-surg floor. A score, of 7 to 10 is generally required, and then, like I said, if less than 7, either this patient's going to stay in the PACU for a little while longer, or if they've already been there for 4 hours, they're headed to the ICU if there's a bed. So remember how to open and close your drains, okay? Remember your hemovac? You've got a nice full drain there over on the other side. You're going to compress that, empty it out, and we're going to keep that drain squeezed while we replace the stopper. Come on, these are very simple things, but not everybody knows how to do them. JPs are going to run the same way, same kind of concept, alright? Dehiscence is a potential complication. So if you've got a wound that has dehisced or avist, you're going to cover that with a sterile dressing soaked with sterile saline, and you're going to call your surgeon right away. Coughing and deep breathing, it doesn't matter if it's abdominal, it doesn't matter if it's chest. These patients are going to want to use splinting to help with pain control with that. So look up, you guys have a case study related to splinting. Pay attention to how you would complete patient teaching. How frequently should you be teaching a patient to do their IS? For pain control, what are you going to be doing as the nurse upon the unit as far as pain control? Are you going to keep them on a regularly scheduled medications, something that they can once again copy as they go home, or are you going to wait until they are complaining of pain before you start giving something? Just some things to think about, and making sure once again that your assessment is thorough and complete. Patient education. So the single most important intervention is ambulation in the postoperative phase. What are our 3 biggest postoperative complications that we can have, or the 3 most common? DVT, pneumonia, and constipation or ileus. Ambulation helps with all 3 of those. You can cough and deep breathe, and that's helping your respiratory and prevention of pneumonia. You can do leg raises in your SCDs, and those help protect against blood clots, right? But ambulation does all 3 of those and hits all 3 of those. And that's why it is the single most important intervention that you can get those patients doing. Some other things that we do include deep breathing, coughing, IS, especially if our patient is unable to ambulate, then we go to these other alternatives and we really push them hard. Mobility, active body movement, getting our PT in there, our OT, but you guys have had some basic introduction to, some simple leg raises and whatnot. You guys have some education to help you teach these patients some of these basic movements, these range of motion exercises. Pain management, making sure that we're keeping up on our pain management, making sure that our patient is adequately covered so that they can do all of these things that we want them to do. Cognitive coping strategies are patients who have a lot of anxiety. That anxiety can come in the way and can inhibit patient teaching from occurring. So making sure that we're educating our patient, we're setting up a clear plan with them, and discussing treatment of anxiety perhaps with their with their admitting physician to make sure that we are taking care of them in all different aspects. And then instruction for patients undergoing ambulatory surgery. So again, all of this information that we do little by little by little over the course of a 16-hour, 18-hour hospital stay, 24-hour hospital stay for those patients who are undergoing ambulatory surgery in a freestanding surgical care unit, they're going to obviously have to have all of that instruction crammed into those 3 hours or so post-operative. Alright, and that concludes your introduction to med-surg in your OB class.